And good morning, everyone. It is April 24th. This is a joint meeting between House Healthcare and Senate Health and Welfare. We have an agenda before us, and for some of you who are out there on YouTube and have noticed that the agenda has changed, we had intended to have some testimony from the Department of Health and the Ethics Network regarding some issues around COVID treatment during the emergency. We're putting that off until next week, and that will give folks time to put together their testimony. And I know we're hearing, I think Representative Lippert at least has indicated he's heard from some individuals who were concerned that that was not on our agenda, but it will be on the agenda. So we'll do that next week. And I'm going to ask Bill if you are interested in saying something. There you go.
Yeah. No, I think it's important for folks to know that we're postponing at the request of the witnesses. That we were prepared to go forward, but the request was to postpone. So we are going to do that and reschedule for next week.
Right. I mean, it didn't make sense to have incomplete testimony, and we'd rather do it right than halfway. So today we're looking at a continued look at the COVID response and getting an update first from DFR and what's going on with insurance coverage relative to COVID diagnosis make sure I get it right. Oh, treatment and prevention. Okay. I was going to say screening, so we'll get an update on everything that's going on at this point. All right, so we have from us with us Jill Rickard. Here you are. Welcome. Do you have prepared testimony for us that we have online?
I do not.
Okay.
I was going to just sort of give you an overview of our emergency rule and just an update on how we've heard insurers are operationalizing.
Terrific. That's fine. And then what we might do, Nellie, is or Julie, get a link to the rule if we can up on our webpage, and we'll try to do that. So thank you. Okay, Jill.
I'm sorry, I can email the rule also.
Perfect. Okay. Why don't you introduce yourself for the record, and we'll listen to your overview.
Thank you for having me. Jill Rickard. I'm the Director of Policy with the Department of Financial Regulation. And I think this rule was really spearheaded by Sebastian Arduengo, who's one of our Assistant General Counsels, who is out on paternity leave right now. So I am sort of pinch hitting. And if there are specific rules about the decision-making process going into this rule, I may have to come back to you, but I think I can, for the most part, speak to this. So we, DFR passed an emergency rule. It's H 2020-03-E, and it covers COVID-19 treatment, diagnosis, and prevention. So there are really 5 main sections of this rule, and please feel free to stop me at any point if you have questions. The first main section deals with COVID-19 diagnosis. So this directs all fully insured plans, insurers to cover with respect to fully insured plans, testing for COVID-19 that is either medically necessary or directed by the state or federal government at zero cost share for members. And then secondly, they also must cover provider office visits, urgent care visits, and emergency services visits to determine whether testing is medically necessary at zero cost share. The second main part deals with treatment. So the rule would direct insurers to cover medically necessary COVID-19 treatment, whether in or outpatient, at zero cost share for members. As well as medically necessary prescription drugs for COVID-19 at zero cost share. There are really none specific to COVID-19 yet. And then thirdly, medically necessary ambulance transport of members either with COVID-19 or suspected of having COVID-19 to and from treatment, recovery, and isolation areas at zero cost share. Section 5 of the rule, the third section, covers prevention. So this is really a federal mandate consistent with the CARES Act. Insurers must cover qualifying preventive services at zero cost share. And this really means if there ever is a vaccine for COVID-19, they would cover this at zero cost share. The section 6 of the rule deals with claims retroactivity. So insurers should process and reimburse claims for these items back to March 13th. Section 7 is out of network services. So it consistent with existing DFR rule, they should cover out of network services for these things if there are no in-network providers available. So we understand that all the major insurers, we've spoken with Cigna and Blue Cross and MVP, are all substantially in compliance with this rule. Most were compliant with the majority of these mandates prior to our passing the rule, which is great. Some are still sort of working on some of the operationalizing of the rule regarding mostly diagnosis codes and communicating with the providers to make sure that they are coding these claims correctly so that they are trigger the no cost share in their systems. So there's a little of that still happening, but they all will be covered retroactively to March 13th. Like I said, most already had these in place, so there's no need to go back and do any reimbursements, but in some cases that has to happen. And we, other than that, haven't heard any concerns with difficulties with this other than just sort of getting systems up to date. I'm happy to answer questions about the why or the how.
Why don't we go to questions for Jill? Any questions regarding what is currently in place? Yes, is that Representative Page?
Yes,
We
ma'am.
have Representative Page, Representative Lippert, and Representative Houghton, and I have them in that order, so I apologize if you put your hand up in a different order.
Okay. I have a question regarding the March, going back to pay the March 13th payment for claims. There's been reports that the COVID-19 issue may have started in our country even before then. And I was wondering, I don't know whether Vermont has had any issues regarding COVID-19 before that date, but if it did, would those claims be covered prior to March 13th?
Well, the March 13th date is the beginning of the governor's emergency, when he determined that we were in a state of emergency, basically. So that is why we went back to that date. Whether there were cases prior to that, I don't know. It's a good question.
Very good question.
It's something to think about. It may also be a question for the insurers as to how that was covered prior to March 13th. It could be that they covered that at no cost share. I'm not sure. We haven't really spoken about that. I can take it back and sort of discuss, but the reason that March 13th date is because that was the beginning of the executive order.
But I think most of what we have done during this process is to have exceptions made during the emergency order. So we'll, but that would be good if you could maybe consult with others about what the administration is thinking there.
Sure.
I've got a long list, Representative Lippert, and then Representative Houghton, and I also have Durfee and Donahue. Thank you.
Okay, thank you. In the course of prior testimony earlier this week, we heard an example given of a serious hospitalization for a patient who ultimately tested negative for COVID-19, but who all medical personnel who treated them said every symptom was consistent with COVID-19 diagnosis, and they treated them as if they were being treated with a COVID-19 medical situation. And I think the question was raised at that point because frankly, it had not occurred to me or perhaps to many of our colleagues that we might in fact have this situation taking place in Vermont. But in this instance, it was described pretty clearly. And I want to understand both from DFR, but then subsequently from the insurers who we have here to testify this morning, if there is a provision for confirmation of no cost sharing and reimbursement by the insurers where the medical personnel treating a patient confirm in their medical view that this is a COVID-19 medical situation that requires their intervention, and what the situation is, and what frankly, just whether no cost sharing would in fact apply, which it would seem that it should. But can you speak to whether the DFR has anything in the rule? And then I'd love to hear from the insurers when we get to their testimony about their approach to this as well.
Well, I know that,
But-
I mean, emergency services visits to determine whether testing is medically necessary are
Right.
covered at zero cost share. In terms
Right.
of treatment.
Subsequent treatment, I think, is the issue.
Again, it's a good question. I don't know the answer to that. I would think it would depend on how it's coded in terms of diagnosis. And I think that's up to the provider. So if the provider, generally, I would think that's based on the test, but if they suspect that the test is incorrect, I assume they could still code it that way. I don't know the answer to that question, and I apologize.
Because we do understand that there are false negatives to the test.
Yeah,
So that we certainly don't want Vermonters who in fact may be COVID-19 impacted
mhm,
and experiencing possibly a false negative. It's hard to prove a false negative, but when the medical personnel say every symptom is consistent with COVID-19 and
Yeah.
we're treating them at that level of intensity, it would seem that medical personnel should be in the position to enter a diagnosis regardless of the test outcome, and then have the emergency rule apply consistent with that. But I think that's an important piece for us to work our way through.
I
Yeah,
agree. And the rule is not specific as to how to determine whether it's COVID-19. It doesn't say you have to have a positive test.
I don't have the rule in front of me, but when you were reading it, I did note that the language, I think, said medically necessary
Mhm.
or directed, and I didn't quite catch the language of the following part, but medically necessary would seem to cover it through, it doesn't specifically refer to a positive test, but medically necessary would seem to allow for the possibility of confirmation by medical personnel involved.
Yeah, and that it is not specific to test. It says health insurers shall cover medically necessary COVID-19 treatment, whether delivered in an inpatient or outpatient setting.
Okay.
So
Well,
I think that would,
I think it would be important for us to have some clarity so that we're not putting, frankly, so that we're not putting patients' families or loved ones through the process of them having to bring forward the question, but rather have us have a clear policy position.
You're right. I think
Understood.
we'll get an update from the insurance companies and how that might be handled by them. But I think that the phrase medically necessary is pretty self-explanatory. After we've sort of heard the testimony, we may want to come back to this one.
Okay, thank you.
I think Representative Houghton is up next.
Thank you. And this might be more of a question for the insurers, but as I read the ruling, it shall be in effect for the duration of the state of the emergency. Curious what the thoughts are, what happens for those patients who are still potentially in the hospital, still get sick after the emergency, and when the vaccine is available, which hopefully will be soon, but probably after the emergency is over. Will that still all be covered?
again, I think that I have to talk to my team about the intent, but at this point, the emergency rule is limited to the state of emergency. There may have been talk about what happens after that. I was not part of those conversations, so I have to get back to you on that.
Okay, thank you.
Yeah, and listen, I think some of that, that may be a policy decision that we have to discuss collectively. and make a determination about what happens in the short term. And then if we get into a second wave, obviously that might put us back into an emergency order, but that's a good policy discussion. Lori, thank you. Maybe not. Representative Durfee.
Hi, good morning. Jill, I'm wondering about situations where in maybe a healthcare setting or some other setting where there were, down here at the Vets Home, for example, it was determined that they needed to do widespread testing of the staff and whether that's, I'm not sure how that was paid for, but whether that would be covered under the rule specifically. And then more broadly, I guess, whether just thinking about sort of the population health, and if we get to a point where there's better availability of the testing, and whether it might make sense from a population health standpoint to be testing more people, whether medically necessary would cover that.
Well, it's medically necessary or directed by the state or federal government. So if the state of Vermont decides for public health reasons to do more widespread testing and it directs that sort of testing, that is covered at no cost share as well.
Thank you.
All right. Okay, let me see. I think Representative Rogers is up next.
Thank you, Jill. I just had a quick follow-up to Representative Colton's question, which is maybe when you look into that, I was curious if perhaps part of what was going on is that DFR wouldn't have the authority under emergency rulemaking authority to make a rule that would extend beyond the state of emergency. Do you think, is that possibly what's going on with the end date?
I have to look at Act 91 directs us to pass the emergency rule, but I'm not sure if it says it must be for the state of emergency. It may, I think you might be right, but we do have emergency rulemaking power generally, but this was directed in Act 91, so I have to check the language there.
Thank you.
Representative Donahue, I did skip over you. I apologize, but you're up.
Thank you. They were just sort of brief follow-ups to two of the prior questions. One is when Representative Lippert was referencing what if a person's negative, because even saying medically necessary, it's medically necessary COVID treatment. And I think that is important for us to drill down, because the medical sources are saying there's a 25 to 30% false negative rate on the testing. So we could have a lot of folks in that category. And the other thing is follow up from the original question from Representative, I was going to say Woodman, Representative Page, is in terms of the start date, because my recollection is the emergency order occurred based on our first several confirmed cases. So we wouldn't want those folks to be left out. Plus, there could have been a number of tests that were negative, but that were diagnostic tests that wouldn't be covered if the start date is limited to the date of the emergency.
So again, I don't know how much testing was done prior to March 13th. That's a good question to follow up on. Perhaps the insurers can speak to how testing was covered prior to March 13th. And I'm sorry, can you repeat your first question? Oh, it's about medically necessary.
Right, that was back to that false negative rate. But it isn't really a question as much as a reflection of why it may be important to really drill down on that issue.
Understood.
Good, thank you. Representative Cordes, and then I'm gonna shift. I'm gonna have a question. Representative Cordes, go ahead.
Thank you. This is a comment for you, Jill, and then I'm hoping that the folks from the different carriers can respond to it at some point when they're giving testimony as well. And it's about the, I believe that DFR has had some discussion about cost sharing for maintenance meds for people with chronic conditions, and making allowing no cost sharing for maintenance meds. So many people are in dire straits financially right now, and there's so much financial uncertainty. I would like to encourage that happen, that cost sharing, there'd be no cost sharing for people that require maintenance medications for chronic conditions.
Is that something that, let me ask a question of Jill. Is that something that is in any of your guidance or rules for insurance carriers, or is this something new?
It is not. Act 91 had directed us to look at mandating the coverage of all prescription drugs with no cost share. And the department did look into that and found it not to be a feasible option at this point. In terms of purely maintenance meds, that is not something that we looked into specifically.
All right.
And
Go ahead, Bill.
Senator, I must say that Senator Lyons and I had an extended conversation with leadership of the Department of Financial Regulation regarding the very question or related questions to prescription drugs in Act 91. And frankly, I'm awaiting a response from the department still, because my understanding was that the department was in fact exploring possible bulletins or emergency rules with regard to prescription drugs. And if that's been resolved, I would very much appreciate the department coming forward with that to us. And if it's still under consideration, I think it's important for us to engage in that. I did intend for us to hear that policy discussion from DFR with our committees jointly, but have been waiting DFR's getting back to us, frankly.
And I apologize for that. I have not been part of that discussion, so I can follow up for you.
I think that was part of Sebastian's, we had a conversation with Sebastian and the commissioner.
And Emily Brown.
And then Sebastian went off on paternity leave. So
Congratulations for him.
yeah.
And just to add, I believe that one of the carriers actually has this in a plan for 2021. So that's why I'm hoping that the carriers can update us as well.
Okay, thank you.
Good, thanks. We'll look at that. Certainly an important issue. So my question was to go to, I'm going to ask my question, and then Senator Cummings, I see your hand is up. You'll be next. I was actually going to ask Jen Carby to help out, and she volunteered
hand
all by herself. So Jen, you want to give us some info?
Yes, Jennifer Kirby, Legislative Counsel. So I did just want to, I was looking at the language of Act 91 as Jill was speaking. And in the section where you had directed DFR to consider adopting emergency rules, you had said it was the intent of the General Assembly to increase Vermonters' access to medically necessary healthcare services during a declared state of emergency in Vermont as a result of COVID-19. And you said during such a declared state of emergency, DFR shall consider adopting and shall have the authority to adopt emergency rules to address certain things for the duration of the state of emergency. So it sounds like that would be an explanation for why DFR's rules are specifically limited to the duration of the state of emergency. I think Jill's right that they have general emergency rulemaking authority to address an imminent peril to public health, safety, and welfare going forward, but specific to these, which may, I think you can make arguments about whether some of these provisions that are being discussed fit the emergency or imminent peril standard. The specific direction that you gave them around emergency rulemaking was limited to the COVID-19 state of emergency. It does say during a declared state of emergency, so it would potentially give them the authority again if there was a second wave with a new state of emergency declared.
Thank
It-
you. That's good.
Senator Lyons, I would just suggest that we have that policy discussion, and it may fall to us to amend Act 91 in one of our COVID bills to be clear that it's our intention to not have this. I think we've been working very hard and furiously at times and fast to try to craft language that addresses the issues in front of us. But as the situation has evolved, I think at least I, for one, would like us at least to have revisit that policy discussion and consider a possible amendment. And I think there would be vehicles for us to do that now that the House and the Senate are both prepared to do remote voting. And I would just also mention that there has been previous discussion, and I'm trying to think the particulars of, but there's been previous discussion of understanding that there may be a period of time, for a period of months at least, following the stated end of the emergency order, where there are going to need to be continuation of policies that have been put in place for that emergency order. And others
So
might help me. I remember a particular discussion
Yeah.
about that.
Yeah, I think that is a good place for us to have a discussion after we've heard from the insurance companies. We might learn something about their plans going forward or not. But I think let's continue with Senator Cummings, and we've got that now on our list of agenda items to somehow get in place. So thank you. Senator Cummings.
Okay, the long tradition of money chairs being the ant at the picnic. Every time there are fiduciary balances required in, the health plans offered on the exchange. Every time we do away with a copay or payment on one part, it has to be balanced by increasing something somewhere else. And some of us at least are getting a little concerned about what all of this might do to insurance rates next year or the year after. And so there's a lot of wonderful things we'd like to do, but it costs money. And at some point, we're going to have to come up with the money, or someone is. So much for the ant.
That Senator, that's your job. You come up with the
That's
money
right.
and then we'll all spend it. No, thank you. I think that is a rational thought.
No one lets me raise taxes.
I'm not sure that's entirely true.
Just property, and we don't do that.
Thank you.
Okay.
That's an appropriate comment. Any other questions for Jill? All right, so let's move on to our insurance carriers, and I always give Sarah and Susan and Jean a opportunity to say who's going first. Sarah, you are first on the agenda today. Do you have an order to your testimony?
I don't think we discussed anything in advance. We'll do
All
whatever.
right, so you're all on your own. There you go.
So Sarah Teachout with Blue Cross and Blue Shield of Vermont, and I'll speak first to the rule, and then I can try and answer some of the questions that you've asked. So as Jill mentioned before, we were already complying with the vast majority of this rule before it came out. A couple of the things that were new were I wanted to mention, because I don't think it was mentioned before, that as part of the treatment, we are including mental health. I think that should be obvious, but I wanted to state it for the record. The medically necessary prescription drugs, we are awaiting FDA guidance on what that is. The piece on transportation, non-emergent transportation is new for us, but we have been able to implement that. And then section 5 that has COVID-19 preventive services, we believe this anticipates a vaccine. And so we're waiting along with everyone else to see what develops in that front. Section 6 is the piece that goes retroactive to March 13th. And we have had a discussion internally about whether or not there could be cases that come up prior to March 13th. We haven't seen anything yet. And it would be up to, I believe, the provider to identify what was a COVID case prior to March 13th. And then section 7 with the out of network, we are already complying with 0903, so that's moving forward. And I wanted to mention that until this particular rule, every self-funded employer group was complying with all the DFR bulletins. We've had the majority comply with this most recent rule, but not all self-funded employers have chosen to comply with this. So we're getting into the stage where it's not consistent across all covered lives. I did want to talk to Representative Pate, somebody's question about whether or not someone who is treated but has not tested positive for COVID-19. This all depends on how the provider codes the case. If they code it as a COVID-19 case, we'll cover it all at no cost share. It's not contingent upon the test, but it's contingent upon the coding that the provider chooses. I'm trying to think of some other questions that you asked. I think that we are continuing to have the calls with the Department of Financial Regulation. The situation is very fluid, as you all know, and I think we'll be discussing with them how to move forward after the emergency period. There's a number of the changes that Blue Cross and Blue Shield of Vermont made that we've made permanently. So things like the store and forward changes, we are not planning on suspending those and then reenacting them on January 1st. That would make no sense for us or the providers, and would add too much confusion to the process after we've done so much in such a short period of time. So not every one of these changes is permanent. For example, the telephone triage calls, as well as the telephone only in replacement of telemedicine, are both temporary for us. And I think we'd like to review those policies and see if they make sense going forward. I think I've hit on most of your questions, but I'm here to answer more if you have them.
All right, thank you. Thank you for that. I actually have a question that hasn't been asked, and I'll ask it now, and then whether or not it's relevant. I've heard from a physician at Dartmouth Hitchcock who was concerned about, I think it could have been an out-of-network question about allowing for treatment at Dartmouth for a Vermonter covered by a private carrier. And I'm sorry, I don't know which private carrier, but just a general question: if the person is at Dartmouth and admitted and being treated for COVID, would your company cover that treatment?
Yes, Dartmouth Hitchcock is in network.
All right, so it's all network. So there, somebody got messed up with that one. I'll have to go back and look at that email and sort them out. I've got Representative Lippert, and then I have Senator Ingram.
Yes, thank you. And thank you, Sarah. That's helpful to understand the distinctions that you made. Two questions. First, it appears that based on what clearly based on what you said, the concern about a false negative or a frankly, a failure to even have a test done somehow. And yet there's clear from the medical provider's point of view that they're treating a COVID-19 medical situation, that if they code it, that it will be covered by Blue Cross Blue Shield in any case, and perhaps that's consistently the case. That is there a clear understanding from Blue Cross and or other insurers to the medical profession that it is the coding that is the determination of insurance coverage for COVID-19? I frankly don't know how this gets communicated or what the medical profession, maybe it's a question we should have for Devin Green or others in the medical who are representing the medical providers. But I just want to make sure that there's no misunderstanding somewhere that someone says, well, they didn't test positive, so therefore we can't blah, 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 you know. So
I'll let
is
Sarah
the question
add.
clear?
Yeah, I'm gonna insert a short comment, and it could be the alliance that's been working together with Jill Olson as the spokesperson. VMS and VAS and others might also
Right.
be communicating. We can ask them, but Sarah, how does Blue Cross and Blue Shield communicate this information?
So we write a medical policy telling providers how to code for COVID-19 coverage in order to have it covered at no cost share. So as long as they code it the way that we've demonstrated to them, it will process it with no cost share, then that's what happens.
Would that medical policy be explicit about that it is not contingent on a COVID-19 positive test?
I need to look at it again.
I would just think that this is an issue where we know about false negatives and where we just want there to not be confusion.
Yep.
Thank you. So, well, I have a second question, but I'll wait till others have asked questions and then come back to me if you would, please.
All right, terrific. Senator Ingram is next, and then I also have Representatives Durfee and Page.
You. So to be another aunt at the picnic, I'm just wondering how financially Blue Cross is able to cover this. Do you have enough in your reserves to be able to manage this without the copays? Do you anticipate, or I don't know, do the carriers have any access to any of the federal money that's coming down the pipeline and any of the bills? Or do you, and then what do you anticipate the effect being on premiums in the future?
Right. All good questions. So I'll answer the easy one first. No, insurers have received no money from the federal government for any of these costs. The second is that Blue Cross and Blue Shield of Vermont is required by the Department of Financial Regulation to maintain member reserves. And that is what comes into play when something unexpected and extraordinary happens. We believe at this time we do have enough in those reserves to pay for what we see so far. The situation could change dramatically if we were in a worst case scenario. That could be very different. But right now, due to all the work here in Vermont, it's looking pretty good. And then I guess the third thing I would say is there's just so many unknowns at this point that we don't have a final answer for you on any of this. We are hearing that there's many providers concerned about the pause in elective procedures, but we are not sure if people are going to be able to go back to their providers at some point and make up for that. We do know that some people could have situations that are worse than they were because of the delays in care. We do know that there has been a substantial uptake in the use of telemedicine over this time period, but all of our data is super preliminary. So I think we just don't know yet what the final impact will be. We're only 4 months into this year, and we've seen how quickly the situation can change. And we are certainly concerned about an additional surge or wave of COVID cases in the fall.
So I will add that some of us, that there's a leadership group in the Senate that has made a request of DFR to keep us apprised of the solvency of insurance companies going forward, and it is linked into elective, it could be linked into some of the elective procedures that are not going on now. And it gets a little bit complex when you start thinking about the emergency process and then what happens at the other end, and how do we ensure that our hospitals, our independent providers, and our insurance companies are all made whole or kept whole during all the process. So that is being looked at.
It's
And
worth noting, Senator, it's worth noting as well that that is in fact a primary responsibility of DFR, the solvency issue for insurance companies. So the DFR has that, their responsibility goes first there, or not first, but it's a foundational responsibility of DFR. And in addition to issuing emergency rules or bulletins for the protection of consumers.
Representative Durfee.
Yeah, Sarah, since you're you're first, I'll ask you the question, and it's really sort of along the same theme. And I'm trying to think about the ant at the picnic and whether I'm the grasshopper asking this question, which I don't think is really the perfect analogy, but I'm thinking about it this way, that we've heard from the hospitals that they're in bad shape financially, and that the reason for that, as I understand it, is they're not getting the revenue from elective procedures and so forth, and possibly because their costs have gone up related to treatment and dealing with COVID, although I'm not sure of that. But in the meantime, Vermonters are continuing to pay premiums at the rate they always have been. So up to this point anyway, it seems that just looking at the equation, that the insurers would be building their reserves. And again, because they're not paying the providers for the elective procedures. So I'm wondering if that's a fair characterization to begin with, and recognizing that there's lots of uncertainty going forward, but whether we might also want to be concerned about providers getting compensated more than they currently are with advanced payments from the private insurers.
So I'm not clear on the last very bit of your question about being compensated with advanced payments, but I do want to mention that yes, we've seen a pause in elective procedures, but we do not know if people will go back as soon as they can to have these procedures, and there is the possibility of a surge in elective procedures at the end of the year or as soon as people can go back. So that's one thing we are watching closely. Not everything has stopped. I know when you hear from hospitals specifically, I think they've probably seen the most extreme portion of this crisis, but there are a lot of other providers who have managed to turn towards telemedicine, and I certainly don't think they've all kept the same level of services that they did before, but we are seeing a broad use and increased use of telemedicine over this time period. Again, we're paying with no cost share for COVID-19 testing, treatment, and other ancillary services that weren't anticipated this year and were not included in the 2020 premium. So that's all new expenses that were never even anticipated at the beginning of the year. And then the last piece I wanted to say on people continuing to pay premiums, we are seeing, due to the economic crisis, many employers and individuals having more trouble paying premiums than they ever have before. And what Blue Cross and Blue Shield of Vermont has done is increased the level of flexibility that we allow both of those groups with paying premiums. And so there is considerable risk for our company on that portion of our activity right now that I don't believe I can quantify yet, but this level of flexibility is something we have never done before, and it's to try to ensure that people remain on commercial health insurance.
Thank you. And I threw a lot into the question, I guess, and just,
It was a big question.
yeah. I mean, I guess two thoughts then. One, it might be helpful at some point for us to hear from you and your colleagues about the, actually, where we are, where we stand today, and recognizing that there's a lot of uncertainty going forward, but how it all sort of nets out at this point, recognizing that there are additional costs that you're expending, and that maybe premiums are not coming in at the rate that they would have in the past. And then just the last point that I think you did actually address was that if there's expected to be a surge in elective procedures coming down the road, that it might be feasible to pay the providers in advance if that would help them cash flow wise.
Oh, okay. I see what you're asking. So we actually have developed 2 programs. They're just beginning now, but we will be doing, if the hospitals choose to do so, we're going to be doing hospital advance payments based on what their previous sort of expected claims levels were. And we're also we've developed a program for small providers to level out their revenue streams as well, recognizing what we think will happen is that many of these services will come back later in the year. So those are 2 programs that we're just starting to roll out with providers to help support them during this sort of emergency period. The last thing I didn't want to talk about a whole lot because there's so many unknowns, but we're still required on May 8th to file our 2021 rate premiums. And I think that it will be very difficult. And so I'm just going to say it right now. We don't have enough data for this year to really know what will happen in 2021, but yet the process is, very prescribed and very long. It's an 18-month period ahead of which we try and do it. So I'm just telling you that we're trying to work on that as well.
Thank you for that. Yeah, thank you. And good questions, Representative Durfee. Just so you know that the information that you have just asked Blue Cross and Blue Shield for, Sarah for, is information I think that DFR is collecting and will provide for us, not just from one company, but from all the companies together, so we can have an understanding of that relationship between the risks and benefits associated with all of this going on in our insurance companies. It's a very good question, and that information is being collected, and we will at some point see it. Sarah, before I go to Representative Lippert, Page and Lippert and Rogers, a quick, not a quick question, but as you're looking at prospective payments, and I'm thinking about a comment you made about some of the self-insured not doing some of the things that Blue Cross and Blue Shield would recommend. How is that all sugaring off with, are there any of the self-insured that are falling into the prospective payment concept at this point? How is that going? Is that a question you can answer? And
Right.
Yeah, I don't know.
So, good question. And I don't know if I've thought it fully out. So, I might have to follow up with you.
Okay.
What we'd be doing would be paying hospitals and independent providers based on some percentage of previous year's claims. And I don't know, what their mix of self-funded versus fully funded insured members are. So I just don't know exactly how it would shake out.
Okay.
The self-funded employers who are choosing not to follow every one of the directives, I think are under a significant amount of economic and financial stress right now, and that is why they're making some of the decisions they are. It also could have to do with some self-funded health benefit plans that are paired with health savings accounts or health reimbursement accounts that the employer has filled. And so it doesn't make as much sense for them to go that way if they've already pre-funded those types of out-of-pocket mechanisms. So there's just a lot of individual variation for employers on why they're choosing those.
Thank you. Representative Page, then Representative Lippert, and then Representative Rogers. So Representative Page, you are up.
Thank you. A couple of questions tagging on to some of the ones that have previously been mentioned. For those individual employers that are having economic stress in paying for the premiums for their employees, how are you helping them? Are you recommending that they contact you if they're having problems with their payments, that sort of thing? I know you're a business. I know you're in it to make money, but you know, how are you helping your these businesses if you actually can? And then the other question I have, and this goes to Chair Lippert, regarding the coding process. Once bills have, you know, once a provider puts in the code and the bills are sent out, how easy is it, or how difficult it must be to have to go back into the system and recode for something that was maybe misdiagnosed, or there wasn't knowledge of what we're facing today? So those are my two questions. Thank you.
Yes, so the first on the businesses, for example, one of the things we're doing is we have payment plans. So if a business can't pay the premiums now or can't pay the full amount now, we've worked out plans for them. I think for some of them, they hope that they'll start to recover as the economy opens up again. So that's one of the things that we're doing. For individuals, we've been working with DVA to follow within the federal guidelines. I'm trying to think of the right word, but there's a period of like a grace period with payment of premiums, and they've extended the grace periods for a longer period of time, where if you're arrear in your premiums, we'll continue to pay the claims for those employees or those individuals. So that's what we're doing there. You know, we looked at it when the crisis first started, and I think we'll be looking at it again as we move through. I don't think anyone knows how long this will last for and what the impact will be. I am not an expert on coding, so I'll tell you that right now. It's easier to code correctly the first time, but we do have a process for adjusting claims if necessary. And so it can be done. I think it's more burdensome for the providers and for us, so it's preferable to code correctly the first time. The COVID-19 specific claims have not processed as quickly because we were, I think, waiting a little bit on guidance from the federal government and Medicare on how they were going to code some of those claims. We were also working with the Department of Financial Regulation and the other payers to try and align the way that we're coding for these types of things, so that we're not all requiring different things of the providers. It's not perfect, but we have tried to code in a similar way. And so I think that will help the accuracy of the coding and also some of the consistency for the providers. So it's not a total answer, but you know, it is part of what we've been working on over this time period.
Thank you. Bill Lippert, Representative Lippert.
Yes, let me first ask Sarah. I think, Sarah, you're in a position to clarify this. Woody suggested, and I don't know that, I don't want to misinterpret what you said, Representative Page, but Blue Cross Blue Shield is not a for-profit shareholder company. So they are not in the business of doing this to turn a profit. And I think Sarah should make clear what the status of Blue Cross Blue Shield is as a corporation.
Thank you. I appreciate
Bill.
I think it's important for people to understand. In fact, Blue Cross Blue Shield has a particular relationship with the state of Vermont under statutory issues as well.
We are.
Thank-
We're a
Thank you,
not-for-profit
Bill.
that is created and you know, a quasi-public entity through the state statutes. We do have a board of directors, but there's no profit with our business. Anything that is in a margin goes to this member reserves that's saved for the future. It's also highly regulated by the Department of Financial Regulation and the Green Mountain Care Board. They look at our reserve levels, our premiums, and the costs of providing the services every year to try and make sure that there is nothing excessive nor inadequate in the business of providing health insurance.
Good. I think that's useful, important for people to have some understanding of that. And that's a somewhat unique situation. Excuse me, folks. So I have a different question, Sarah, and it goes to the self-funded plans, for which your Blue Cross has a fair number, a part of your book of business. We, of course, as the state of Vermont, do not have the ability because of federal, what we sometimes refer to as the ERISA provisions. We don't control and cannot control what self-funded plans provide in their policies. I think that's a given, and I mean, that's maybe not technically the exact language, but is that a fair representation, Sarah?
I believe so, with the two exceptions of the government self-funded plan.
Right. Yes. Thank you for the several government, for state employees and for teachers. Is that correct?
Correct.
But as you've described, I think for some of us, it's often been kind of a unclear situation as to what policies they do and do not follow from DFR, because DFR is in fact an agent or part of state government who has responsibility, as we've been discussing here today, to issue emergency rules, bulletins, and see that reserves are kept intact, et cetera. What I find myself wondering, and so it's often been stated that many times self-funded plans will voluntarily adopt the provisions of a DFR rule or bulletin, but they're not required to. And again, I think that's a fair, accurate description. It occurs to me today, and this is a question I think Jen Carby and DFR perhaps, and Blue Cross, is there the authority of the state of Vermont to ask self-funded plans to publicly be clear about what they provide and do not provide in terms of their benefits, so that in fact we as policymakers and the public at large, but we as policymakers have a clear understanding of where self-funded plans deviate from the requirements of the legislature or DFR. And it just today, for the first time after many years of discussing this, it seems like it's been a bit of a black hole as to what happens for and I don't mean that in a pejorative way, but it does sound that way, it's been unclear. And when we raise this issue, it's always one of, well, we don't control them. Blue Cross doesn't control them. We work with them. They're self-funded. They make their own decisions. All of that is true, and I understand it. But can we require or ask, require that there be a public accounting of what their provisions are and are not consistent with state policy and with DFR requirements? And
I'm happy to start with that if you want.
I'd have you do that.
So my sort of off the cuff response is no, we probably can't do that. And that's because of the way the ERISA preemption language is written. So it says the federal law says that the provisions of ERISA, which say that, that regulate employee benefit plans, not just health plans, but include those, that say, it says that the provisions of the ERISA subchapter shall supersede any and all state laws insofar as they may now or hereafter relate to any employee benefit plan. And that language about relating to has been interpreted different ways by different courts, but in general, anytime a state is looking to do anything having to do with how an employer or what benefits an employer offers to their employees, we are preempted.
Okay.
So you could probably informally ask if any employers would be willing to share that information, or if employees want to share that information, but we can't have a state law that relates to employee benefit plans.
Perhaps we could find a way to highly encourage voluntary sharing of what their plans cover and don't cover related to state policy and DFR bulletins.
Well, I don't think you could do it by law.
I can't do it by law, but I don't want us to move too far away. I think this
Okay, fine.
this is broader.
That's why I was reluctant, but
Yeah,
the issue was brought up by
yeah.
Sarah in terms of self-funded plans and where they participate and don't. and I
Well,
thought,
that was my question. And I was very concerned about whether or not our carriers could influence those self-funded plans during the emergency. And
Right.
it's like the answer is no. So
I mean, I think the relationship between the carriers and the self-funded plans for which they offer the
Right.
administrative services is potentially a different question, and you may be able to have some aggregate reporting from the carriers on what their self-funded plans do and don't tend to include. But I think as far as doing anything legislatively, that would likely be problematic.
Can we
Right.
even ask who the self-funded plans are in Vermont?
Let's think about, let me talk to some of the others and
Let's set that to the side, but I really do think,
let's let that one go, because we're hearing now from Blue Cross and Blue Shield. We have two other
yes,
insurance
I agree.
companies, and we're going to have other questions, but this continues to be an issue that I think we're all very much engaged and concerned about. So
And I think there is a COVID-19 relationship to this issue. So
No
I think
kidding.
it brings it right to the fore.
yes, it
Thank you.
does.
Thank you.
Representative Rogers, you are up, and then I have Representative Cordes and Representative Donahue. And I'm hoping that we can wrap around Blue Cross and Blue Shield and then move on to MVP and Cigna. So it is Lucy Rogers, go ahead.
Representative Durfee and others pretty much covered my thoughts. The only thing I would have to add pertaining to just the understanding that we aren't entirely sure how all this will shake out, but it's possible that the insurance companies will end up spending more money than they had accounted for this year. And it also seems quite possible that they would end up spending less money than they had accounted for this year. And so the only, I think it's pretty much been covered. The only thing I would add is it seems that the systems we have in place would ensure that if there is less money spent, that it would end up coming back to Vermonters through reduced premiums. And it's my hope that that would be the case.
Thank you. Representative Cordes, question for Blue Cross and Blue Shield.
Yes, I wanted, thank you. I would like to hear from Blue Cross Blue Shield about my comment about no cost sharing for maintenance medications. And before I get to another part of my comment, I just want to say I acknowledge the economic realities that we're in right now, both as a state and nationally. And I think that we as lawmakers have an obligation to be as creative as possible to create a system, and this is forward-looking, obviously, that is able to provide healthcare to everyone with no barriers to access. So that the practical part of my concern about no copays for maintenance medications is to prevent exacerbations of those chronic conditions that would lead people to have to seek help in the emergency room On my unit in cardiology, when people can't afford or stop taking their medications for cardiovascular disease, for heart failure, they come into the hospital with much more expensive needs, and then add risk to themselves and the healthcare providers of contracting or transmitting COVID. So there's a very practical reason for wanting to ensure that people are able to take their very necessary medications for their chronic conditions, and hence no cost sharing. And if the other insurance carriers could also answer that question when they testify, I'd appreciate it.
So sure, this is Sarah Teachout with Blue Cross and Blue Shield. And we did discuss what was in Act 91 with the Department of Financial Regulation. We do have some concerns about inadvertent consequences of eliminating, and the law said eliminating all cost share for prescription medications. A couple things that we have concerns about are that when we eliminate cost share, we do see an uptick of people moving to brand drugs and an increase in the overall cost of prescription drugs as a result. I know that a lot of the concerns are around people with high deductible health plans, and we're very limited by the IRS in what we can do for those people without invalidating their high deductible health plan. And then the third concern we do have is around drug shortages. And I know this has come up in the past, and sort of the stockpiling and hoarding of medications that we want to manage if possible. And then the last thing is we have broadened our refill policies significantly in one way to try and address the issue that you described. So I think that's all on that particular one.
Can I just clarify? I've heard it mentioned a couple of times about no cost sharing, that Act 91 talked about no cost sharing for prescription drugs. It actually talked about modifying or suspending the deductible requirements only. So not the not copay or coinsurance, but deductible requirements. And it did carve out high deductible plans if that would be problematic for the reasons that Sarah stated.
Can I?
Yeah, thanks for that
follow-
clarification, Jen.
May I make a follow-up?
Do you have a question? If it's a follow-up question, that would be great.
Yeah, it seems like I am not an insurance carrier, but it seems like some of the programs that insurance providers have in place already, like the tiered programs to encourage use of generic medications, or to incentivize that there are mechanisms that insurance carriers can use to address all of the concerns that you just brought up, Sarah, including generic versus brand name.
You know, Representative Cordes, I think we're getting into some weeds right now, and I think that yeah, but so let's hold that thought, and maybe we'll get further information from MVP and Cigna, and after we've heard had more complete testimony from all three carriers, we can come back to some open questions that people have. So let's do that at this point. And I appreciate everything you're suggesting. We have one more question from Representative Donahue.
Thank you. Yes, and this is actually more towards DFR follow-up to Representative Lippert. I think we need to all look from the state's perspective about our obligation for communicating information under ERISA. We may not be able to tell self-insured companies that they have to broadcast it, but when we make big announcements about, look at this great stuff, no more cost sharing for COVID-19 treatment, even I, who knows really well all of the ERISA stuff, when I first heard that, thought, oh, because of the emergency, was there a way that we actually achieved that for everybody? And I think we have to be careful in press releases to say, this doesn't necessarily cover everybody. And us as legislators sharing with our colleagues, it sounds like it, but it doesn't really, because if I was a consumer out there and I got hit with a bill because my employer was not getting involved with this, I'd be pretty stunned and I'd be saying, I was misled. I was told this was all covered. So I'd be suggesting to DFR in press announcements and all of us that we can do a big part in that.
Thank you. And we have a work cut out for us. I know that. All right. I think that we'll move on to MVP and Susan Gretkowski. And Susan, if you could simply begin after introducing yourself with an overview of what MVP is doing. And I know that there are similarities between all the carriers and what's happening, and maybe identify some of those things that you think are unique. That would be helpful.
Sure. So can you hear me?
Absolutely.
Okay. So Susan Gretkowski, MVP Healthcare. I will run through my testimony, which I think touches on what you just asked for. And then, certainly we can follow up with questions. So MVP is supportive of this emergency rule. We have fully implemented it. We actually had started waiving cost share prior to when the rule was issued. So that had already been in place. There were system configuration issues that we had to go in and make, to make sure we were catching the appropriate claims to be waiving the cost sharing for. So that led us directly to the provider community and how they are coding for these claims. And MVP has what they call a fast fax. It's basically an ability to send out blast faxes to providers. And we have been doing that regularly on this, advising providers exactly what modifiers to put on the codes, all of that, so that when the when the claim comes in, we can, in the system can sort it out to say, okay, this is a COVID claim or associated with COVID, and therefore we would be waiving all the cost sharing. As far as members go, there's a very prominent space on the our homepage on our website. Clearly labeled COVID information, and it talks about the waiving of the cost sharing, and it walks folks through all of that. So those are really the two vehicles that we use to communicate with providers and members. Like Sarah said, we did have a call with DFR earlier this week. We walked through the rule with them. Our medical director was on the phone as well. So we did ask for a little more definition around the preventive service. And we're going to have continuing conversations with DFR going forward. Because again, we want to make sure that we're capturing everything that should be captured to be waiving the cost sharing for. So this is something that's ongoing, and we're keeping a close eye on it. We're fine with the out-of-network coverage piece. And what our medical director told DFR was that there's a senior leadership team that is meeting daily to look at updates on COVID treatment, because things are changing so fast, new stuff coming out all the time. And so they said that there are new codes coming out all the time. So again, the system configuration is ongoing, probably will be ongoing for a long period of time. The only thing in the rule that we do not currently cover is non-urgent ambulance transportation, but we did add that in as a new benefit based on this rule. So I took a page and a half of notes here. So let's see. So prior to the effective date of the rule, did we get any claims prior to that? As best I know, the answer is no. So, you know, I can look into that further and get back to you. As best I know, the answer is no. Then the question of, is there a provision for no cost share if the treatment the patient gets is COVID when it turns out it wasn't? So again, I think as Sarah said, it all depends on how it's coded. If we get a claim coded with, say, the COVID modifier, we're going to go ahead and pay that. So let's see. So after the state of emergency, how were we going to cover this? Since the rule is only in effect for the state of emergency. So I think that's still under discussion internally. I mean, obviously we're headquartered out of New York, and New York is clearly the hotbed. We don't cover Manhattan. You know, we cover down basically just to north of Manhattan, but and then out to Buffalo. So, you know, there's a lot going on in New York on this. So let's see. Just looking at all of my, in terms of the financial situation of MVP, we have been asked to go before the Green Mountain Care Board next Wednesday at their regular weekly meeting to talk about what we're doing from a clinical perspective, and then also sort of how our financials looking. So we have our regional medical director who will be speaking to the clinical side, and then we have our controller who will be talking about the overall financial situation on that. So that is what I was going to say. Again, I'm just looking through some more of your questions.
The question, I think, regarding the coverage of medications for chronic conditions during the emergency.
Yeah. Well, again, Vermont already has in place a statute that limits a member's out of pocket for prescription drugs, any kind of prescription drug. So that is really what would be controlling in this area. And it's $1,400 out of pocket for an individual a year and $2,800 for a family. So then that everything cuts off at that point and we cover 100%. So, that's that one.
Can I interrupt and just say, I think that's an important piece of information that I think is not always widely understood or remembered. So can you just state that again for us, or maybe Jen Carby can state it? Because I think it's important for all of our members to understand that provision around prescription drugs. That came up in our, just with Senator Lyons and I were meeting with DFR, and that was frankly part of the rationale for, at this point in the year, that many people would have already begun to meet that. But Jen, can you clarify what the statutory situation is with that provision?
Sure. So
Sorry to
in
interrupt you, Susan, but I think that's important for us to understand more fully.
under existing law in 8 VSA section 4089I, there is a requirement that health insurance plans limit a beneficiary's out-of-pocket expenditures for prescription drugs to no more for self-only and family coverage per year than the minimum dollar amounts in effect under section 223C to AI of the IRS code for self and family coverage respectively. What that means is that's the minimum deductible level at which a plan qualifies as a high deductible plan under federal law. And so those are the $1,400 individual and $2,800 family coverage amounts that Susan was just mentioning. But then there's also additional language because for a high deductible plan, we're not allowed to waive the deductible requirement for somebody with a higher deductible plan than that. So somebody has to meet their actual deductible under the high deductible plan before these limitations would kick in. Except they can offer first dollar coverage for prescription drugs to the extent permitted under federal law, because there are certain medications like insulin that the IRS has determined are preventive and therefore can be offered first dollar.
Okay, thank you for that.
I don't know if that helped or made it worse.
No, no, it was good. And we did something with that just a couple of years ago. I remember presenting something to the Senate on that.
Right, so that had come up a few years ago in the context of the bronze plan design and the pressure that it was putting on bronze plan design to have this piece of the plan design locked in.
Okay. Susan, is there anything else?
No, why don't we just move to questions? So,
Okay. Questions for Susan Gradkowski and MVP. This is what usually happens. I feel sorry for Sarah. She did the heavy lift.
I'll
Whoever
go
goes
first
gets
next
it.
time. Yeah, I'll go first next time.
All right,
I have a question.
go ahead, Bill.
And this is a question for Susan, but then for the other carriers as well. Someone else alluded to it, the loosening or broadening of refill policies during the COVID-19 emergency period. Could you clarify whether the ability to have that the refills filled for a longer period of time so that you don't have to make the same number of visits or the same frequency of visits and expose yourself to potential COVID, coronavirus, et cetera. Is that at the request of, can the consumer request that and have it implemented, or does it require the physician to modify a request to a pharmacy?
Because it's on the books and it's our policy, we did like a two-step. We broadened, instead of getting 130-day supply, you could immediately get another 30-day supply. So that was the first step that we took. And now we're allowing folks to get a 90-day supply.
Right, that's
So
fine.
really doesn't matter, I think, how the prescription is written. It's that, if you got a prescription for, say, a 30-day supply, you can go and get the full 90 days at the pharmacy. It doesn't need anything special from the physician.
Could I ask for Blue Cross to clarify the same question? Because that's not the experience of some people who, I'll say I personally have experienced the pharmacy saying, no, we can't do that. You have to get your doctor to intervene. And I thought that's not what my understanding was, but I would like to have clarity, not just for me personally, but for the world generally of Vermonters.
So I think that's a good question to ask Blue Cross and Blue Shield. I will say that yesterday, Senate Health and Welfare took extensive testimony regarding prescriptions and timing of prescriptions and what and some of the details around the pharmacies that are pharmacists, the local pharmacists and others right now. So, but we'll let Blue Cross and Blue Shield answer that. And I would, I mean, you can go back and look at the live stream, our YouTube, but it does get pretty detailed. But Sarah,
Well,
can you answer the question?
Sure.
Regarding the 30, 60, 90-day prescription piece?
Yeah, so it's not an unqualified answer. Blue Cross is allowing up to 180-day
Right.
refill for 2 90-day prescriptions.
Right.
But it does not apply for every type of drug. So it doesn't apply to specialty drugs, and it doesn't apply to drugs that require, special treatment and handling.
Right.
And then there's these certain circumstances for, I believe, the 5 drugs that we were talking about with Senator Lyons that are coming under additional scrutiny because of what's happening with COVID-19.
Sure.
So it depends a little bit on your drug. And then the other thing that we are hearing.
But those are exceptions to the rule, right?
Yes.
The vast
So the way-
majority of drugs don't fall under those exceptions.
Correct. The way that Blue Cross wrote the policy is that we allow the pharmacist the discretion to extend the prescription for the full 180 days. And then you also included in Act 91 a piece allowing pharmacist discretion without permission from a doctor. So there are several components in play here. And then the last thing is that we do know a number of the pharmacies, especially the chain ones, have their own policies regarding refills. And so I think a little bit what is happening here is some confusion about what is the insurer, or what is the prescription, what is the insurer or PBM policy, and then what is the pharmacist drugstore policy on those drugs. So there's a little bit of confusion between all those layers.
So do the chain pharmacies policies supersede the carrier's policy? I'm not talking about the exceptions. Because I realize there's exceptions. We gave the pharmacists the right to. We do not want drug hoarding, and especially around, we've heard all the horror examples, but I'm talking about regular drugs that people are taking on a maintenance basis that are regularly prescribed every 30 days. And so that's my question.
Okay, so that should be, with the pharmacist's discretion, you should be able to get the full refill.
Right.
Okay, thank you.
Jen, did you want to add anything there?
I would just add a little bit from yesterday's testimony. There was definitely discussion about concerns with shortages of all drugs, in particular because both the active drug ingredient manufacturers and supplies and the inactive ingredient suppliers are all facing limitations, some of these in China and India. And so there's restrictions on what's available to pharmacies. And so out of concern about their own supplies and the supplies of the wholesalers, there can be limitations that are put on what they will fill that would be, I think, would come before what the restrictions from the payers. So meaning if somebody came in and wanted a 180-day supply and Blue Cross was okay with that, it may not get that. It may not get to the point of billing it to see if Blue Cross would accept it if the pharmacy's policy is we're not giving more than a 30-day supply of this out of concerns with our supply.
It gets complicated. So let's go to Representative Christensen.
Hi, I'm still not clear. Is allowing people to get a 180-day supply of medicine contributing to the lessening of the stockpile, or is it something much bigger? We weren't there for testimony yesterday.
Yeah, I think it's bigger than that. And I would recommend that if you are interested in the topic to listen or to the YouTube, because we're starting to get off again. It's everything, you know what John Muir said, if you try to separate one thing out, everything comes along with it. And that's where we are. And it's difficult. And the insurance companies kind of get stuck in the middle of all this. So all our questions are good, but difficult to answer. Are there any other questions for MVP, for Susan?
Could I?
Depends.
I'll raise a question.
Go ahead.
Having asked Blue Cross Blue Shield to clarify their corporate structure, maybe MVP and Cigna could be asked the same question, just so people understand in terms of
Sure.
for-profit, nonprofit, et cetera.
Sure. So for MVP, MVP is a not-for-profit corporation. We are domiciled in New York, as you know, but we are not-for-profit.
I appreciate it. Since we've asked Blue Cross that question, I think we should ask each of the carriers. Thank you, Susan.
Okay.
All right, good. Now we'll move on to Cigna and Jean Kennedy. And you are unmuted. Terrific. Thank you for being here and being patient.
Oh, that's fine. I keep getting a sign on my computer that my internet connection is unstable. So I don't know if that means my voice is going to go out or not.
You're good right now.
Okay. Jean Kennedy. I'm a contract lobbyist. I have a firm called JB Kennedy Associates, and Cigna is one of my clients. I have to apologize first and tell you that I prepared incorrectly for this morning's testimony. I thought it was going to be on the emergency rule. And I've been around the building long enough to know that questions would go way beyond that. And
So it is on the emergency rule, and the questions that we've asked have taken it further, so.
that's all right.
it's
That's not a problem, except that a lot of those, because of how I work with Cigna, I can't answer for you. I've been trying to I work with a woman named Christine Cooney. She's on a phone call in Massachusetts right now, so can't call into this. But I will send her a lot of your questions, all of your questions, and she could be on sometime if you wanted more directly from her. Some of these questions that have come up, I can address. We were happy to be involved in the process of DFR and the Blues and MVP, and it was a good process, and we appreciated it. As with the other two, some of the issues addressed in the rules we were already doing. And in one of the things that has been asked is about the time it started, and these rules start with the emergency order in Vermont. In general, Cigna has been doing some of these things for weeks, and they've gone back to March 2nd as a date. I don't know how that was determined, but they're doing it from March 2nd on, and so have had to do some back billing and back coverage on that. But so they're a little ahead of the, ahead of the Vermont March 13th executive order date. Like the other companies, I know we've talked about it, not in depth, but when the crisis is over. And I don't have any idea even when it's going to be lifted in Vermont. And Cigna, of course, has that condition in 50 states. So that's all I know about the dates. As somebody asked about coding and the providers, I have, I think, one guidance and an updated guidance that I thought I had sent to you, but I will, both your committees, but I will check this afterward and resend it. Several pages of guidance for providers on the coding and all. So that I think, as with the other two companies, witnesses have suggested that if it's coded COVID, it's COVID. And so it's covered with the same rules that, but I will check all these questions out, and the answer I get you, I'll fall back to and check them. We have, we cover about 58,000 lives in Vermont. So we're way small compared to the Blue Cross Blue Shield. But most of our policies are uninsured. I mean, self-insured, not uninsured, self-insured. So it does bring up those questions. I don't have numbers for you on the, even on the balance between our fully insured and self-insured, but also on how many are complying. However, anecdotally, I've heard that many of them are and have been from the get-go with the COVID situation. I don't know legally if that's information on numbers that they would give us, but I will certainly ask them. And I don't know about the names of the businesses that actually have a self-insurance plan and who work out through negotiations with their employees and all what is going to be covered and what isn't going to be covered. But I have heard that many of them have been very, very responsive to covering the COVID issues. The question on the maintenance drugs, I think you received some good information on this morning. I will certainly go back to Cigna with that particular question. I do know that I got some information the other day that the Express Script is the pharmacy, there's a company that covers Cigna's drugs now. There may be still some of, we had a PBM at one time, and I think rolling out Express Script has been with us, I want to say a little over a year, maybe longer. But some policies had not finished, and so it's not completely, but it's largely Express Script now. And I was reading some stuff as you were going through different questions, and Express Script has advised their pharmacists to override what is called the refill too soon issue, and to for this time during the emergency, so that you won't have that. And they are doing 90 days. I don't know about 180 days, but we are doing 90 days in some cases. Other questions that you had? I had 5 or 6 down. Yeah, I think those are the ones that I noticed, but that I would be getting back to you on, where all over the country we're dealing with the different emergency rules and all in each state, because we're not all doing them the same. But I think as you listen to some of the answers this morning, it's kind of a testament to all the things this legislature has thought of over the years for better coverage for people and easier coverage for people. I thank you for all you're doing. Your lives have been turned upside down, as all of our lives have been, both in and out of work. But it certainly is important to review all these things. I know that I haven't answered the questions as fully as you would like, but I will be happy to have Christine be on with you if you want. And if you have other questions, I can try to answer them.
But thank you very much. And I think you have actually responded to the question around the rule, so that is extremely helpful. And we all appreciate your comment about how our lives are different right now, and the work that we're doing away from people. The social distancing is sometimes very difficult, but when we're in this situation, it's even more difficult because we can't walk down the hall and talk with each other, and that makes a huge difference in getting our work done. So questions for Jean?
Anything but Jean.
Anything but Jean, I figured. Okay. Questions for Cigna? Wow.
And let me say, I really appreciate Sarah going first all the time. she and Susan do such a great job for the industry, and they are in it all day, every day. And so they are more prepared to answer your more in-depth questions. However, I don't ever mind going back and getting the answers for you. I'm happy to. And if there are others that come up to anyone, you can find me in the lobbyist listing and email me with any other questions that you might have from
All
us.
right. Yeah, thank you. Representative Lippert has a question.
Well, again, Jean, I just wanted to ask you to clarify Cigna's corporate structure or corporate status as well, since we've asked the others to comment on it as well.
Well, you know what? It sounds like a legal question to me. I always assumed we were profit, but I honestly would like to say, maybe Jill knows for sure, but I don't think we're nonprofit.
You are either, but but I think since we've asked the others, I want to make sure that we
you just wanted everyone on the record. Okay.
Cigna is it correct, Jill, that Cigna is a for-profit corporation?
Yes, that's my understanding, with a publicly traded one with shareholders.
Yeah.
Publicly traded for-profit corporation, accountable to shareholders and a board of directors.
Yes, and a board of directors and a CEO.
Yes, but I think it's important just to recognize that in the breadth of the healthcare industry in the world.
I may have sent. Yeah, I also should mention something that I may have sent to you earlier this week. And believe me, if you haven't seen everything that people have sent, I wouldn't be surprised at all, because I think your email has probably gone up incredibly since this all has started. Cigna did announce Monday a joint venture with Brave New Heart, it's called, and it's a fund that they have established with New York Life for the families of people who essential workers, as health workers, have maybe died because, or been ill because of the their working situation. And the two companies together have put in $50 million, and it will be matched with another $50 million. And it's a fund that people affiliated with healthcare workers can apply for.
My question about that, it was really rewarding to see that. But that is any individual any individual family that's been affected by this. It doesn't necessarily mean someone who was covered by Cigna.
Oh, no, you mean as an insurance policy? That was my understanding. I asked that same question myself.
Okay.
And that's my understanding.
Thank you. All right. Any other questions? Oh, good. All right. Thank you all. It's been another great day. We have learned a lot, and it's probably a good thing that our other topic has been postponed to another day. Because now we are continuing in our tradition of finishing early. I want to thank Susan and Sarah and Jean for being here with us and providing us with the information, and Jill for bringing us up to date on some of the things that are going on with at DFR on the new guidance information, new rule. So thank you all.
Senator Lyons.
Last comment.
Before we finish, it has come to my attention just in the last 24 hours that the Joint Rules Committee today at 4 o'clock will be hearing about the newest federal legislation and its relationship to additional funding for hospitals. And so I just want members of our committees to be aware of that testimony this afternoon at 4 o'clock. And if people are, so that people can tune in to listen to understand what additional resources may come for hospitals in the COVID-19 situation.
Thank you for that. Yes, I'm going to be at that meeting. That's very good.
As am I. I think we were, as the chairs of the two committees, we were invited to participate.
Any other comments? I hesitate to say that, but because we all could comment for a long time. But listen, thank you very much. It's been great being together again, and we'll look forward to our next joint meeting. So we are finished, and Nellie, you can take us offline. Thank you.
Bye, everyone.
Okay. Ending live stream.